Welcome back to the deep dive. We are tackling a beast of a topic today, and I mean that in the best way possible.
You really are.
We're looking at a massive two-part download that, it essentially covers the entire spectrum of psychiatric care.
It does. It's really the ultimate software versus hardware discussion when you think about the human mind.
Exactly. Software versus hardware.
And it's a rare combination to see them together like this.
Yeah.
Because usually, when you're studying this stuff, you're in one building or the other. You're either in the law library looking at statutes.
Right, the ethics and the rules.
Or you're in the anatomy lab looking at neurons. But the source material we have today, this really comprehensive deck by Sam Donnelly, an MSN, RN, and psychiatric mental health nurse practitioner, it forces us to merge those two worlds.
Which is exactly what happens in the real world, right? You can't just treat the biology without navigating the rights of the person who is, attached to that biology.
You have to. They are completely intertwined.
So our mission today is, well, it's ambitious. We are going to mention every key term, every single concept, and every legal track in this material.
All of it.
But we're going to do it in a way that doesn't just feel like a list. We're going to build mental visualization so this information doesn't become this jumbled ball of info in your head.
Yeah, categorization is going to be our best friend today.
Yeah.
We have to. We need to distinguish the smallest details that set these concepts apart from each other.
Exactly. So to set the stage, I want to start with the visual anchor from the very first slide of our source material.
Okay.
It's an image of the scales of justice, the one old school heavy metal scales. And this is really the theme for the entire first half of our discussion. It's all about balancing the need for care with civil liberties.
That balance is the core tension of the entire field.
Yeah.
It really is. On one side of that scale, you have the safety of the patient and, the safety of the public. We have a duty to keep people alive.
The duty to help.
But on the other side of the scale, you have this fundamental human right to freedom, to autonomy, to, self-determination.
And it's not always a clean balance, is it?
Never. It's messy. It's so difficult. And that is exactly why we need a rigorous framework to navigate it.
Okay, so let's build that framework. You said two distinct frameworks today.
Two frameworks. First, we'll build the legal and ethical framework, the rules of the road. And then second, we'll get into the biological framework, the wiring under the hood.
The software, then the hardware.
Exactly.
Okay, let's start with the software then. The ethical code we operate by. Donnelly outlines some very specific ethical principles. And I want to create a mental map for this. For everyone listening, I want you to visualize a compass.
Okay, a compass?
But this isn't your standard north-south, east-west compass.
Yeah.
This compass has 7 distinct points.
7 points. This is our moral compass for psychiatric care.
Perfect. So let's start with the North Star of this compass, the one guiding light, and that is autonomy.
Autonomy is the absolute foundation. Everything comes back to this. It's the client's right to make their own decisions.
Sounds simple enough.
It sounds simple, right? Let people choose. But in a medical context, and especially in psychiatry, this gets really complex really fast. It's not just about letting a patient do whatever they want.
No.
It's about respecting their agency, their personhood.
So if a patient says, I don't want that medication, but we know that medication will help them, autonomy says we have to respect that.
Generally, yes. Autonomy means accepting that people have the right to make decisions that we, as providers, might think are wrong or, even bad for them, provided they are competent to make them.
Provided they're competent. That's the key phrase there.
That is the key.
Yeah.
It's all about assessing their understanding. Can they process the information? Do they get the risks and benefits? Are they acting in their own best interest as they see it? We have to protect that agency even when it is incredibly frustrating for us.
That feels like a hard check on the ego of any medical provider. You want to fix people, you want to help, but autonomy says you can't force the fix on them.
Precisely. It's their life, their choice.
Okay. So autonomy is our North Star. Let's move around our compass. We have 2 points that, I think often get jumbled together, so let's meticulously separate them. Beneficence and nonmaleficence.
Yes. This is a crucial distinction.
They sound like synonyms. Do good and don't be bad.
They're related for sure, but the distinction is critical. Think of them as the gas pedal and the brake pedal of ethics.
Oh, I like that. Gas and brake.
Beneficence is the gas pedal. It's the active drive to do good. It is an action you take to help someone.
Okay, so give me a concrete example from the source material.
An act of beneficence is, say, a nurse identifies that a patient is in severe emotional pain from depression. Giving them an antidepressant or spending an hour doing therapeutic counseling with them,
Yep.
that's beneficence. You are adding something positive to the equation. You are actively intervening to help.
You're pressing the gas.
You're pressing the gas.
Yeah. Okay, so beneficence is active. It's doing. Then non-maleficence must be the brake pedal.
Exactly. Non-maleficence is the absolute foundation of the Hippocratic Oath. First, do no harm. It is often about refraining from an action that could hurt someone. It's about restraint. It's about hitting the brakes.
So it's not just about, the obvious stuff like not stabbing someone.
Right. It's much more nuanced in psychiatry. The example Donnelly provides is perfect. Imagine a patient who is acutely agitated, maybe from mania. They are pacing the hallway. They're shouting. They're disruptive.
Okay.
But, and this is the key detail, they are not threatening anyone. They aren't lunging at staff or other patients. They are just loud and moving.
The impulse, I imagine, from a stressed out staff would be to stop them, to restrain them, to make the unit quiet again.
Exactly. But restraining them would cause physical and psychological trauma. It's a physical violation. So by refusing to use restraints in that moment, the nurse is practicing non-maleficence. They are avoiding the harm that the intervention itself would cause. They're hitting the brakes.
That is a crucial distinction. Beneficence is giving the med to help. Non-maleficence is withholding the restraint to avoid trauma.
You got it. Gas pedal, brake pedal.
I think we've categorized that one clearly.
Yeah.
Okay, moving to the fourth point on our moral compass. Justice.
Justice. And in this context, we're not talking about courtrooms and gavels.
Right.
It's about distribution. It means fair and equal treatment for all, regardless of race, religion, gender, language, socioeconomic status, anything.
And this isn't just a theoretical, be nice to everyone. This has real logistical implications for a hospital unit.
Huge logistical implications. The source gives a perfect example of this with language barriers. Let's say you have a ward full of English speakers and one patient who only speaks Mandarin. Justice demands that the Mandarin-speaking patient gets the exact same quality of care.
The same understanding.
Same understanding as everyone else.
So just smiling and nodding at them and handing them a pill is not enough.
No, absolutely not. Justice compels you to get an interpreter. It compels you to find a way to communicate complex medical information, side effects, treatment options accurately.
Oh.
If you don't, you are treating them unequally. And that is a major ethical violation of justice.
Okay, that makes sense. That brings us to point 5. Veracity. This shares a root with verify, so I'm guessing it's about truth.
It is. Veracity is the duty, to be honest.
Yeah.
The duty to tell the truth. Even, and this is the hard part, especially when the truth is uncomfortable or might make the patient anxious.
The example in the material is a classic nurse moment. A client is about to get an injection, maybe an antipsychotic, and they ask that question we all dread. Is this going to hurt?
The temptation, the easy way out, is to say, no, it's fine, don't worry about it. That's the comforting lie. But that violates veracity.
And it breaks trust, right?
It shatters trust.
Right.
Ideally, yes. The ethical answer, as per Donnelly, is, to be honest, you say, you'll feel a little pinch from the needle, and then the medicine might burn a bit as it goes in. You prepare them for the reality.
Because if you lie about the pinch,
Why should they ever trust you again when you're talking about a serious diagnosis or the side effects of a long-term medication? Veracity is the bedrock of the therapeutic relationship.
Okay, next point on the compass. Fidelity.
Fidelity is all about loyalty, faithfulness. It's about keeping your promises, big and small. In psychiatry, patients so often feel abandoned or powerless. If you make a promise to them, you absolutely must keep it.
What's a common promise that really tests this principle on the floor?
A very common one is, I'll be there with you. A client might be terrified of a doctor coming in to deliver a difficult diagnosis or to change their entire treatment plan. They might ask the nurse, could you please stay in the room with me when they come?
And the nurse is probably swamped with a million other things to do.
Always. But if that nurse says yes, fidelity dictates they stay. Even if they're busy, even if it's awkward, even if another patient is calling. You stay because you pledged your loyalty to that patient support in that moment. You follow through.
Okay, that makes a lot of sense. And finally, the 7th point of the compass. You called this one the tricky one, paternalism.
This is the one point on the compass we try to avoid steering toward. But it's so easy to drift there, often with good intentions. Paternalism is assuming the right to make decisions for another person because you believe you know better.
The old father knows best.
That's exactly it. And it can be masked as benevolence, which makes it so insidious.
How so?
The example given is a nurse ordering a food tray for a patient who is maybe too depressed to fill out the menu. The nurse thinks, oh, I'll order them the chocolate ice cream because everyone likes chocolate, and maybe it'll make them happy.
But they didn't ask the patient what they wanted.
They didn't ask. They removed the patient's choice. It seems so harmless. I mean, it's just ice cream, but it reinforces a dynamic where the provider has all the power and the patient has none. It is a direct violation of our North Star.
It clashes directly with autonomy.
A complete clash. So even in the smallest things, like choosing ice cream, we have to protect the patient's right to choose for themselves.
Okay, so let's recap our moral compass, the 7 points. We have autonomy, our North Star, beneficence, the gas pedal, nonmaleficence, the brake pedal, justice is about fairness for all, veracity is truth-telling, fidelity is keeping promises, and paternalism is the trap to avoid.
That is the code. That is the software we try to live by.
Yeah.
But of course, we don't operate in a vacuum. We operate under the law.
And let me tell you, the legal side of psychiatry is just filled with myths. I want to play a quick game here if you're up for it.
Let's do it.
Let's call it Hollywood versus reality. I'm going to throw a scenario at you that people think is true, probably from watching movies, and you correct it based on Donnelly's slides.
Okay, let's clear the air.
Myth number 1. Once a patient is admitted involuntarily, they're committed against their will, they lose all their rights. They are essentially prisoners who have to take whatever pills the doctor hands them. True or false?
That is a massive myth, and it's one that really scares patients. Understandably, it's absolutely false. The reality is that an involuntary status does not strip you of your right to informed consent regarding medication.
Wait, so you can be locked in the hospital, but you can still say no to the treatment they're offering?
Correct. You can, unless there is a specific, separate court order for treatment over objection, or there is an immediate emergency where safety is at risk. A competent patient can say no to medication. We cannot line people up and force-feed them pills just because they are on an involuntary hold.
That is a huge distinction. I think most people get that wrong.
Most people do.
Okay, myth number 2. Hypa is absolute. A psychiatrist or a nurse can never, ever tell anyone what a patient says in a session. It's like a priest's confessional booth.
Also false. Confidentiality is a fundamental right, but it is not absolute. We have something called a duty to warn.
A duty to warn. Okay, what are the big exceptions?
The biggest one is a risk of harm to self or others. If a patient makes a credible, specific threat and says, when I get out of here, I'm going to kill my neighbor, John Smith, confidentiality ends right there. We have a legal obligation to report that to the authorities and, in some cases, to John Smith himself.
Okay, so harm to others. What else?
Also, any suspicion of elder abuse or child abuse must be reported. And certain reportable communicable diseases. In those specific high-stakes cases, public safety trumps an individual's right to privacy.
Got it. Myth number 3. If I get committed to a psych ward, I lose my civil rights. I can't vote in the next election.
Hard false. That is completely untrue. A mental illness diagnosis does not disqualify you from citizenship. You absolutely keep your right to vote. In fact, the hospital staff should help you get an absentee ballot if you request one.
Wow. Okay, last one. Myth number 4. If a patient is being really rude, shouting insults, or just refusing to follow the unit rules, the staff can put them in seclusion or restraints to teach them a lesson.
Absolutely not. 100% false. That is illegal, it's unethical, it's assault. Restraints are never to be used as a punishment or for staff convenience.
Never.
They are purely safety tools, and they are only for situations where there is an imminent danger of physical harm to the patient or to others. Using them because someone is being rude or non-compliant is a gross violation of that patient's rights.
This myth-busting is great, and it leads us right into the patient rights triad that's detailed in the slides.
Right. There are 3 big pillars here.
First, we have the General Patient Bill of Rights, which just guarantees humane care and treatment.
Then you have the ADA, the Americans with Disabilities Act, which is a federal law that prevents discrimination against anyone with a physical or mental disability.
And the third one, which we just touched on, is confidentiality, the right to privacy.
And I want to zoom in on confidentiality for a second, because there's a scenario in the source material that really tests this principle. It's presented as a pop quiz, but let's treat it like we're on a real shift.
Okay, set the scene for me.
You're a nurse on the unit. A patient you have a good rapport with calls you over and says, I need to tell you something really important, but you have to promise me you won't tell anyone.
Oof. Red flag immediately. You can't make that promise.
You can't, but you listen. And the patient whispers, I hid a sharp knife under my mattress because my roommate is yelling at me all the time and I need to be able to protect myself.
Wow. Okay, so ethical dilemma squared. You have this implied promise of confidentiality, but you also have a lethal weapon on a locked psychiatric ward.
Exactly. The source material asks, what do? Do you keep the secret to maintain your rapport? Do you just take the knife quietly and not tell anyone?
Well, based on our moral compass, non-maleficence, do no harm, and beneficence, do good both scream that I have to prevent a potential stabbing.
Correct. The harm to self or others exception kicks in immediately. You must report this to the entire healthcare team. You cannot keep that secret. It's a safety imperative.
But then what about veracity? The duty to be truthful. What do you say to the patient who trusted you?
And that's the nuance. That's what separates good care from just, protocol. You don't just sneak the knife away and lie about it. You have to look the patient in the eye and say, thank you for telling me this. I cannot keep this a secret because this affects the safety of you and everyone else on the unit. I am required to report it to the team right now.
So you are honest about the fact that you are breaking confidentiality.
Yes. You maintain veracity while prioritizing safety. It is a very, very tough conversation to have, but it's the only ethical way to navigate that situation.
That makes total sense. Now let's talk a bit about the future. What if a patient knows they have a cyclical illness like bipolar disorder? They know they might lose their decision-making ability in the future. Can they plan ahead? Can they protect their rights beforehand?
Yes, absolutely. This is where advance directives come in, and specifically, psychiatric advance directives.
So it's like a living will, but for mental health treatment.
Exactly. Think of it as a letter to your future doctors that's written by your present will self. When you are lucid and stable, you can write down exactly what treatments you consent to or refuse if you become incapacitated in the future. If I am manic, I consent to this medication, but not that one. I do not want ECT, things like that.
And can you also appoint people to help you make those decisions?
Yes. You can assign a power of attorney. More specifically, a durable power of attorney for healthcare designates a proxy. It could be a spouse, a parent, a trusted friend, to make health decisions for you when you can't make them for yourself. It's a powerful way of extending your autonomy even into moments when you can't speak for yourself.
Okay, you've used two words now that sound really similar, but the deck draws a very sharp line between them. That's competency and capacity. Slide 10 really wants us to know the difference. Help us categorize these so we never mix them up.
This is one of those classic distinguish the smallest things moments. They're not interchangeable. Competence is a legal term. It belongs in the courtroom. A judge is the only person who can declare a person legally incompetent.
So it's an official legal status.
It is, and it's a general status about whether you are legally able to handle your affairs, sign contracts, manage money, that kind of thing.
Mm-hmm.
Capacity, on the other hand, is a clinical term. It belongs in the hospital. A doctor or a clinician determines capacity.
Okay, so competence is the gavel. Capacity is the stethoscope.
Perfect analogy.
Okay.
And capacity is fluid and task-specific. You might lack the capacity to make a complex medical decision while you're acutely psychotic, but you might still have the capacity to decide what you want for dinner. It can change hour by hour.
So you can lack capacity but still be legally competent.
Correct. Most people in the hospital who lack capacity are still legally competent. A judge hasn't taken their rights away.
That's a huge clarification. Now that we know who decides, let's talk about how people actually get into the hospital, the admission spectrum.
Right. We have two main lanes, like you said before. The first is voluntary admission. This is the ideal situation.
The person raises their hand and says, I need help.
Exactly. The patient recognizes they're struggling and comes in on their own. They sign themselves in, and because they came voluntarily, they maintain all their civil rights. They're free to leave, technically, even against medical advice or AMA.
Technically.
Well, if a voluntary patient tries to leave AMA, but the clinical team assesses them and believes they are now a danger to themselves or others, we can then initiate the process to convert them to an involuntary status. But they can't just be held against their will without that formal process.
Okay, and the second lane is the one everyone thinks of, involuntary.
This is commitment. Mandated treatment without the patient's consent. And this is a massive removal of a person's liberty, so the legal bar is and should be very high.
What are the criteria?
It generally requires three things to be met. 1, a person has a mental illness that requires treatment. 2, they are unable to provide for their own basic needs, food, shelter, safety. And 3, the most important one, they pose a risk of harm to themselves or to others.
That danger piece seems to be the trigger for everything.
It's almost always the main trigger.
Okay, let's apply this. Donnelly gives us a lineup of 4 potential patients. Who gets the involuntary bed? First up is patient A, who has schizophrenia and believes he is the king of England.
Okay, a delusion.
Patient B is very depressed and had a suicide attempt, but it was a year ago.
So history, but not current.
Patient C has borderline personality disorder and just an hour ago assaulted a homeless man with a metal rod.
Oof,
And
okay.
patient D has bipolar disorder and is pacing the room and shouting.
Right, this is where we have to be really clinical and precise. Being the King of England is a delusion, but is it inherently dangerous? Not necessarily.
Right.
A suicide attempt a year ago is very important clinical history, but it's not an emergency today. Pacing and shouting is agitation, but like we said before, it's not necessarily a danger.
The patient C.
Patient C, assault with a weapon. That is immediate danger to others. That is the clearest, most unambiguous legal trigger for involuntary admission on that list. The law steps in when public safety is immediately compromised like that.
That makes it very clear. Now, since our source material is from New York, we have a very specific set of legal tracks for how these admissions happen. This is technical, but we need to map it out. I'm picturing 3 railway tracks leaving the station.
Let's walk down each one.
Mhm.
Track 1 is the emergency track. This is your classic ER admission. The law calls it the 15-day hold, or a 9.39 in New York State mental hygiene law.
Okay, a 15-day hold. What's the process?
Here is the timeline, and it's very strict. You are examined upon arrival by a physician. That's hour 0. Then, strictly within 48 hours, a second doctor, specifically a member of the psychiatric staff, must also examine you and confirm that you meet the criteria for admission.
So you need 2 signatures to keep someone against their will in this track.
You need 2 signatures within that 48-hour window. If that second doctor doesn't sign off in time, or if they disagree with the first doctor, the patient must be released. It's a critical check and balance on the system.
Okay, that's track 1. What's track 2?
Track 2 is the medical certification track. But on the street, everyone calls it a 2PC. That stands for a 2-physician certificate.
Another 2 doctors. How is this different?
The duration. This is for a much longer hold up to 60 days. This is usually used when a patient clearly needs long-term care but refuses to accept it voluntarily. Maybe they're deteriorating in a nursing home or at home and the family is desperate.
So it's not usually coming through the ER.
Less often. The process involves an application, maybe by a concerned relative or a social services official, plus 2 separate physicians have to certify the illness and the need for hospitalization.
And track 3.
Track 3 is CPEP. That's the Comprehensive Psychiatric Emergency Program. You can think of this as the cool-down track. It's a very short-term hold, only up to 72 hours.
So what's the goal of a 72-hour hold?
The goal isn't a long-term admission. It's crisis intervention. It's to give the person a safe place to sober up, to come down from a crisis, to get stabilized, and to allow the team time to do a thorough evaluation.
So what happens at the end of the 72 hours?
The team has to make a call. Is the patient well enough to be released with a safety plan? Are they willing to stay voluntarily now that the crisis has passed? Or if there's still a danger and refusing care, do we need to convert them to one of the other tracks, like the 15-day hold?
So 72 hours, 15 days, 60 days, those are the buckets. Now, before we leave the legal side completely, we have to talk about the physical reality of safety on the unit. Restraints.
The last resort.
Donnelly provides a really helpful visual here, the hierarchy of restriction. And for everyone listening, I want you to visualize a staircase. We're starting at the bottom.
This is the least restrictive means doctrine in action. You always want to be on the bottom step if you can. Step 1, the very bottom of the staircase, is verbal intervention. Just talking, de-escalation. Hey, I can see you're really upset. Let's talk about what's going on.
If that doesn't work, what's step 2?
Step 2 is diversion or redirection. Changing the subject, changing the environment. Hey, let's walk over here and look out the window, or how about we go to the art room and draw for a bit?
And step 3?
Step 3 is providing a calm environment. Lowering the lights. Turning off a loud TV. Reducing the stimulation on the unit. Maybe offering them a quiet room to sit in by themselves.
Okay, now step 4 is interesting. PRN medication. That's an as-needed medication. Why is giving someone a pill or an injection considered less restrictive than physically tying them down?
That's a great question. It's because a chemical restraint, which is what PRN medication is, allows the patient to eventually regain their own internal control from the inside out, without the trauma of having their body physically immobilized by force. Being physically tied down is considered the most extreme, most traumatic, and therefore most restrictive option.
So that brings us to the top of the stairs, step 5.
Step 5, the last resort, is seclusion or mechanical restraints.
Where?
Seclusion is being placed in a locked room alone. Mechanical restraints are the physical devices that immobilize a person's ability to move.
And if you get to step 5, you can't just leave them there and walk away.
Oh, absolutely not. The rule is
You must release them as soon as it is safe to do so. And while they are in restraints, they require continuous one-on-one monitoring. You have to check their circulation, offer them fluids, help them with activities of daily living like using the bathroom. It is a high-intensity safety protocol, not a timeout room.
Okay. We have built the legal and ethical framework. We've got the compass, the rights, the different admission tracks, and the staircase of restraints. Now, everyone take a deep breath with me.
Here we go.
We are leaving the courtroom and the ethics committee, and we are entering the laboratory. It's time for part 2, the bio-basics.
This is the hardware discussion. We can't understand the behavior if we don't understand the machine. All those legal rights and ethical principles we just spent time on, they exist to protect a person whose biology is, for some reason, misfiring.
So let's start with the big picture, the map of the brain, neuroanatomy. And for our visualization, I want everyone listening to physically do this. Hold your hands out in front of you and cup them together like you're holding a grapefruit. That is your brain.
I'm doing it.
The entire outer surface of your hands, that's the cerebrum or the cortex. We need to map the 4 lobes of this cortex.
Okay. Let's start at the front, the tips of your fingers. This is the frontal lobe.
The frontal lobe, what does it do?
This is the CEO of the brain, the conductor of the orchestra. The prefrontal cortex lives right at the very front. It handles all of our executive functioning, making decisions, planning for the future, controlling our impulses, having insight into our own behavior.
So when you hear about someone having a total change in personality after a head injury or making wildly risky decisions out of the blue, the CEO is out to lunch.
The CEO has left the building.
Exactly.
Damage here leads to massive issues with emotional regulation, judgment, and social behavior. ADHD, schizophrenia. A lot of this is rooted in a dysregulated frontal lobe.
And there's a very specific area in the frontal lobe that's mentioned, right? Broca's area?
Yes.
Broca's area.
Broca. It sounds kind of like broken. That actually helps you remember it. Broca's area is responsible for speech production. It's the motor control of speaking, forming the words. If you have a stroke in Broca's area, you get what's called Broca's aphasia. You know exactly what you want to say. The thought is crystal clear in your mind, but you cannot physically form the words. It is incredibly, profoundly frustrating for people.
Wow. Okay, now let's move back from our fingertips to the top of our cupped hands, sort of where your knuckles are. This is the parietal lobe.
The parietal lobe is the sensor, or you can think of it as the brain's GPS. It processes sensory input like touch, pain, and temperature, but it also handles spatial direction, knowing where your body is in space without looking.
And it helps you identify objects.
Yes, by touch. If you close your eyes and I hand you a key, your parietal lobe is what tells you it's a key, just from the shape and feel. Damage here can cause something called neglect, where a patient literally ignores one entire side of their body in the world. Or agnosia, the inability to interpret sensations correctly.
Okay, now let's go to the back of our hands, down by the wrists. The occipital lobe.
The occipital lobe is the eyes. It has one job and one job only. Visual processing, color, shapes, movement, facial recognition. It all happens back there.
So in psychiatry, this is key for understanding visual hallucinations, right?
Absolutely. If a patient says they see a monster in the corner of the room, their physical eyes are working just fine. The problem is that the occipital lobe is misinterpreting signals or just firing on its own, creating an image that isn't there.
And finally, let's tuck our thumbs in on the sides of our hands, the temporal lobe.
The temporal lobe is the ears in the library. It's on the side right by your ears, so that's easy to remember. It processes auditory information from your ears and also olfactory or smell information.
And it has the counterpart to Broca's area, right?
It does. It houses Wernicke's area.
So Broca was about speech production. What's Wernicke?
Wernicke's area is for receptive language. It's about understanding speech. If this area is damaged, you get Wernicke's aphasia. You can speak fluently, the words come out easily, but they're often a jumbled word salad that makes no sense. And crucially, you can't understand what other people are saying to you.
And you called it the library, too.
Yes, because the temporal lobe is also deeply, deeply connected to memory formation and mood regulation.
So that's the cortex. That's the outer shell, our cupped hands. But now we have to dig deeper inside the grapefruit to find the subcortical structures.
Right, below the cortex. And we have to mention the basal ganglia. This is a cluster of structures responsible for movement. It handles automatic behaviors and muscle memory, like riding a bike or typing.
So why is this important for psychiatry?
Here's the connection. Many of our older psychiatric meds, the first-generation antipsychotics, accidentally hit the basal ganglia while they're trying to treat psychosis. And that's why you see patients with those terrible motor side effects, the tremors, the shuffling gait, the muscle stiffness. We are trying to treat the mind, but we hit the movement center by mistake.
And what about the cerebellum? That's at the very base of the brain.
Balance and posture.
Yeah.
If that's off, you get ataxia, a loss of coordination, and a stumbling walk.
Okay, now for the main event. Let's go to the emotional core of the brain, the limbic system. This is a whole cast of characters, and I want to personify them so we can remember who does what.
I love this idea. Let's meet the team. First up, the hippocampus. Let's call it the librarian.
Librarian, why?
Because the hippocampus is what converts your short-term memories into long-term memories. It takes the experiences of your day and files them away on the shelves for later retrieval.
Yeah.
In Alzheimer's disease, the librarian is one of the first to go on strike, and that's why you can't form new memories.
Okay, the librarian. Next up, the thalamus.
The thalamus is the relay station, or the grand central station of the brain. It sits right in the middle. Almost all sensory, vision, touch, hearing, taste comes here first, and the thalamus directs the traffic. Okay, vision, you go back to the occipital lobe. Sound, you go over to the temporal lobe.
You said almost all. What's the exception?
The only sense that gets a VIP pass and skips the relay station is smell, olfaction. It goes straight from the nose to the emotional and memory centers of the brain.
Which explains why a certain smell can trigger such a powerful instant memory or emotion.
Exactly. Next on the team is the hypothalamus.
Hypo means below, so it's below the thalamus.
Right, and the hypothalamus is the thermostat. Its job is to maintain homeostasis, to keep the body's internal environment balanced. It controls hunger, thirst, body temperature, your sex drive, and your sleep-wake cycles.
So when a patient with severe depression stops eating or can't sleep, it's because the thermostat is broken.
The hypothalamus is dysregulated, that's right.
And finally, the most famous one, the amygdala.
The amygdala is the alarm system. It is our primitive, almond-shaped center for fear, aggression, and emotional memory. When you get cut off in traffic and you feel that instant white-hot surge of rage, that's your amygdala hijacking your brain before your frontal lobe, the CEO, has a chance to step in and say, hey, calm down, it's not a big deal.
So in anxiety and trauma, the alarm is just stuck in the on position.
It's a hypersensitive alarm, exactly.
The slides also mention the limbic midbrain nuclei. This sounds like the factory floor of the brain.
It is. This is where the chemicals are actually made. The ventral tegmental area, or VTA, is the main dopamine factory, and the locus coeruleus is the norepinephrine factory. These deep, primitive structures are constantly pumping out the neurotransmitters that then go and bathe the rest of the brain and create our moods and thoughts.
Speaking of pumping out chemicals, we need to zoom in even further. We've looked at the whole brain, now let's look at the individual cells that make up the brain, the neuron. Slide 28 gives us the classic diagram, but I want to visualize the neuron as a tree.
That is the classic analogy, and it works perfectly. The soma is the cell body. That's the ground where the tree stands, the home base with the nucleus. The dendrites are the branches reaching up into the air. They are the receivers. They catch the signals, the chemical messages from other trees.
And the axon.
The axon is the long trunk of the tree. It's the sender. It carries the electrical signal down, away from the home base. And at the very bottom, you have the terminals, which are like the roots of the tree. That's where the message leaves this tree to go and talk to the next one.
And there's something wrapped around the trunk, right? The myelin sheath.
Yes. Think of the myelin sheath as the rubber insulation on a copper wire. It's a fatty substance that wraps around the axon, and it has one crucial job: to speed up that electrical charge. If that insulation starts to break down, like it does in multiple sclerosis, the signal slows down or just shorts out completely.
The slides also mention a really important concept here, neuroplasticity.
This is one of the most hopeful concepts in all of neuroscience. The brain is not concrete, it's plastic. It can remodel itself. Neuroplasticity is the ability of your neurons to change their structure and their function based on experience. Learning a new language, exercise, good nutrition, therapy, all of these can literally build new connections and strengthen pathways.
But the flip side is also true.
The flip side is true. Viruses, toxins, chronic stress, and trauma can weaken connections and prune them back. But the brain is always capable of change.
Okay, now let's watch this tree in action. Let's talk about neurons firing. This is on slide 33. This is an electrical process, and for this, let's visualize a rechargeable battery.
Okay, let's break down the action potential. Stage 1 is the resting state. The neuron is just sitting there waiting. The battery is charged. The inside of the cell is negatively charged. It's loaded with potassium ions, K+, and the outside is positively charged, loaded with sodium ions, Na+. It's polarized. The bowstring is pulled back, ready to fire.
Stage 2, the trigger, the signal comes in.
Depolarization. A signal from another neuron hits the dendrites. This causes the gates on the cell wall to fly open, and sodium, no plus, rushes into the cell. Because all that positive sodium is rushing in, the inside of the cell suddenly flips from being negative to being super positive.
And that's the spark.
That is the spark. That's the action potential. That wave of positive charge shoots all the way down the axon like a lightning bolt.
Okay, what's stage 3?
Repolarization. The spark is passed. The cell needs to cool down and reset. So the sodium gates close, and now the potassium K plus gates open. All that potassium flies ODT of the cell, which brings the charge inside back down to negative.
The final stage.
Stage 4 is the reset. Now all the ions are in the wrong places. So the sodium-potassium pumps get to work. These little molecular machines work hard to push the sodium back out and bring the potassium back in, putting everything back where it belongs so the neuron can fire again.
So it's this incredible rapid dance of ions. Sodium in, potassium out, and then reset. But here is the plot twist. On slide 34, the electrical signal travels all the way down the trunk. It gets to the roots, the terminals, and then it hits a cliff. It hits the synaptic cleft.
This is the gap, this tiny fluid-filled space between neurons. And electricity cannot jump that gap. It's like a car reaching the edge of a river. It can't just drive across. It needs a ferry boat.
So the signal has to change?
It has to transform from an electrical signal into a chemical one. When that electrical action potential hits the terminals, it triggers calcium channels to open. This calcium influx is the signal for these little bubbles, or sacs, called vesicles, to merge with the cell wall and dump their chemical cargo into the gap.
And that cargo is the neurotransmitters.
Exactly. These chemical messengers, dopamine, serotonin, all of them float across the river, across the synaptic cleft, and they look for a parking spot on the other side. They're looking for very specific receptors on the dendrites of the next neuron.
And slide 35 describes these receptors with the lock and key analogy.
It's the perfect analogy. Each receptor is a highly specialized protein shape to fit only one type of neurotransmitter. A dopamine molecule is the key that can only fit into a dopamine receptor lock. It can't start the serotonin car.
And once that key goes in the lock, the message is delivered and it triggers a new electrical signal in the next neuron. But we can't just leave all those chemicals floating around in the gap forever.
Right. The signal would just keep firing.
Uh-huh.
We need a cleanup crew. There are two main ways this happens. Some neurotransmitters are broken down by enzymes right there in the cleft, but many undergo a process called reuptake.
Reuptake.
This is like a tiny vacuum cleaner on the first neuron that sucks the leftover chemicals back up to be recycled and used again. And this is the mechanism for our most common antidepressants, the SSRI selective serotonin reuptake inhibitors.
So they block the vacuum cleaner?
They block the vacuum cleaner for serotonin. This leaves more serotonin floating around in the synaptic cleft for longer, which gives it more opportunities to hit the receptors and keep that good mood signal going.
That explains so much about how these medications actually work at a mechanical level. Now let's meet the chemicals themselves, the neurotransmitters. We have a whole cast of characters in slides 29 and 30. They're categorized into excitatory, which is the gas pedal, and inhibitory, the brake pedal. And then there's a third category called neuromodulators. How are those different?
Think of a standard neurotransmitter as a direct text message from one person to another. It's fast, it's specific, one-to-one. A neuromodulator is more like a generic PA announcement over a loudspeaker or a social media blast. It diffuses more slowly through the brain tissue, and it affects whole groups of neurons at once, making them more or less sensitive to other signals. Dopamine and serotonin often act as these big-picture neuromodulators.
Okay, let's run through the big players on the list. I'll name the chemical, you give me the vibe or the so what for psychiatry.
Acetylcholine.
The vibe for acetylcholine is data access. It's excitatory, it governs memory, learning, and intellect. The so what is that in Alzheimer's disease, the cells that make acetylcholine die off. The data access is lost. That's why memory fades.
Next, dopamine DA.
The vibe is desire and control. It's excitatory, it's the motivation chemical, the pleasure and reward chemical, but it's also crucial for smooth motor control. The so what is that dopamine is the ultimate Goldilocks chemical. Too much dopamine, you get the positive symptoms of schizophrenia like hallucinations and delusions. Too little dopamine in the motor pathways. You lose motor control and get Parkinson's disease. It has to be just right.
Serotonin.
SC.
The vibe for serotonin is stability. It's also excitatory. It helps regulate our emotions, our sleep cycles, and our appetite. It's the great stabilizer. The so what is that low serotonin is the classic biological marker for depression and many anxiety disorders.
Norepinephrine. The vibe is alertness, excitatory. This is the fight or flight chemical that gives you focus and energy. The so what is that too much norepinephrine can cause anxiety, panic attacks, and that feeling of being constantly on edge. Too little can cause lethargy and poor concentration.
GABA, that's gamma aminobutyric acid.
Yes, GABA. The vibe is chill. This is our primary inhibitory neurotransmitter. It is the universal brake pedal of the brain. The so what is that when you take a medication like Xanax or Valium benzodiazepine, what you're doing is boosting the effect of GABA. You are pressing the brain's natural brake pedal to stop the racing thoughts of anxiety.
Glutamate.
Glutamate's vibe is go. It's the main excitatory neurotransmitter in the brain. It's involved in everything, but especially learning and memory. The so what is that too much glutamate is actually toxic to the brain. It's a phenomenon called excitotoxicity. It can literally excite the neurons to death.
And finally, the slides list neuropeptides like endorphins and CRH.
These are larger molecules that act as messengers. They're often the stress and pain managers. Endorphins are your body's natural morphine. They kill pain. And CRH, corticotropin-releasing hormone, is what kicks off the body's entire stress hormone cascade.
We are in the home stretch now. We've looked at the microscopic level with neurons and neurotransmitters. Now let's zoom all the way back out to the whole body systems. The nervous system hierarchy on slides 31 and 32 is another tree diagram.
Okay, at the very top of the tree, you have the nervous system. It immediately splits into two main branches. Branch 1 is the central nervous system, the CNS. That's easy. It's the brain and the spinal cord, the command center. Branch 1 is the central nervous system, the CNS. That's easy. Branch 2 is the peripheral nervous system, the PNS. That is everything else. All the cables and wires running out to your tongue and your fingers and your organs.
And the peripheral system splits again.
It does. It splits into the somatic nervous system. This is the voluntary stuff, you deciding to pick up your cup of coffee. And the autonomic nervous system, the ANS. This is the involuntary automatic stuff, your heart beating, your lungs breathing, your stomach digesting. You don't have to think about it. It just happens.
And the automatic system, splits one last time into those two famous states of being.
The two states that are in constant tug of war. You have the sympathetic nervous system, fight or flight. When this is activated, your eyes dilate, your heart races, digestion stops. It's the adrenaline dump that prepares you to face a threat. And you have the parasympathetic nervous system, rest and digest. This is the calming system. The heart slows, digestion kicks back in, you relax.
And in psychiatry, we are so often treating patients who are just stuck in sympathetic overdrive.
That's a perfect way to put it. Their body is physically ready to fight a saber-toothed tiger, but they are just sitting in a classroom or at the grocery store, and that mismatch is what we call an anxiety disorder.
Okay. Finally, we have to acknowledge what the slides call the new frontier. This is on slides 37 and 38. The brain doesn't just float in a jar, it's connected to everything. What are these other contributors to mental health?
First up is psychoneuroimmunology. It's a mouthful.
Yes.
It's the study of the link between your mind, psycho, your nervous system, neuro, and your immune system, immunology. We now know for a fact that chronic depression or stress suppresses your immune system's T cells. A mental illness can literally make you more susceptible to physical sickness.
Then there's chronobiology.
This is the study of your body's biorhythms, your circadian rhythms, and the data is very clear. People who disrupt those rhythms, like night shift nurses or people with erratic sleep schedules, are at a much, much higher risk for developing mood disorders.
And the really big one these days, the gut-brain axis. I keep hearing about this everywhere.
It's a massive paradigm shift. It's the idea of the enteric nervous system. Your gut has its own nervous system, its own brain. And here's a fun fact. The vast majority of your body's serotonin is actually made and stored in your gut, not in your brain.
Wow.
Now, that gut serotonin doesn't cross the blood-brain barrier to affect mood directly, but the health of your gut microbiome communicates directly with your brain via the vagus nerve. Your diet dramatically affects your mood. It's not a myth anymore. It's established science.
And lastly, genetics and epigenetics.
Right. Genetics is the hand of cards you are dealt. Genetic susceptibility. You might be born with genes that give you an increased risk for depression. Epigenetics is how you play that hand. It's the interaction between your environment and your genes.
The slide specifically mentions social determinants of health.
Yes. Things like poverty, early childhood adversity, trauma. These experiences can create little chemical marks on your DNA that literally change how your genes are expressed. So a person might have the gene for schizophrenia, but it only gets turned on because they experienced a severely traumatic environment as a child.
That is the ultimate synthesis of everything we've talked about. We started with the scales of justice, this abstract ethical concept, and we ended with epigenetic markers on a physical DNA strand.
And they are completely, inextricably connected. Why do we fight for justice on our moral compass? Because we now know that social justice issues like poverty and inequality cause epigenetic changes that can damage the frontal lobe and dysregulate dopamine.
This is incredible.
Why do we fight so hard for nonmaleficence, for doing no harm? Because we know that trauma triggers the amygdala, it spikes norepinephrine, and it can lock a patient's entire nervous system into a sympathetic state for years.
It's all one system. You can't separate the software from the hardware. If you only understand the biology, you're just a mechanic working on a machine, and you're ignoring the human soul. But if you only understand the ethics, you're a philosopher who can't actually fix the broken engine.
You need both. You need the compass, and you need the battery. That is the entire essence of modern psychiatric care.
That was a massive, massive download. We promised at the top we would cover every single term in Sam Donnelly's deck, from paternalism to the synaptic cleft, and I really think we did it.
I think we hit them all.
So for everyone listening, just take a moment to review those mental maps we built today. The 7-point moral compass, the 5-step staircase of restraints, the hand-brain model of the lobes, the neuron visualized as a tree, and the battery firing of the action potential.
If you can visualize those 5 things, you can navigate this entire complex field.
That was incredible. Thank you for diving so deep with us. Slide 39 in the source material notes that if you have questions, you can contact Samantha Donnelly directly at downstate.edu. Stay curious, protect your frontal lobes, and we will see you on the next deep dive.
Take care, everyone.